Hi everyone, I am Dr. Madan Pandian from India. Today we are going to discuss a case of adhesive capsulitis for which I have performed a shoulder joint hydrodistension with saline by a slightly different approach than the conventional posterior glenohumeral approach or the rotator interval approach. This is something which I call it as the SHAC axis, that is the shoulder anterior capsular axis to get into the joint space for performing a hydrodistension with saline. Very limited literature is available with respect to performing these blocks actually. This is basically performed as an alternative to suprascapular and axillary nerve blocks, particularly when there is a technical difficulty in performing these blocks at its proximal level. You can actually inject into this space between the deltoid fascia and the subscapularis fascia, and one more injection beneath the subscapularis myotendinous junction close to the capsule, the anterior capsule, so that you achieve a good block for mobilization of the shoulder with 4 plus 4 ml of local anesthetic with or without steroid. Also, it can provide possibly an access to the shoulder joint. Particularly, that is the point which I want to reiterate and discuss here. So what are the requirements? The patient can be very well in a supine position, or sometimes a beach chair will help. The arm has to be put in a little bit of extension, not essentially external rotation. It can be achieved by maximum external rotation. That is, the subscapularis muscle can be stretched posteriorly and the myotendinous junction can be exposed by performing a maximal external rotation, which is important because like in a painful patient, in a patient with adhesive capsulitis, it is likely to be very painful, for which you can actually place the limb facing towards the sky so that you achieve that much of external rotation, which is enough to expose the subscapularis muscle and exposes the myotendinous junction. With external rotation and abduction, you could see the coracobrachialis and the biceps brachii muscles are displaced, allowing the visualization of these interfacial planes, that is between the deep lamina of the deltoid fascia and the superficial lamina of the subscapularis. Once the injection into this facial space is achieved, we can proceed towards the glenohumeral pericapsular space by crossing the subscapularis muscle with the needle. By injecting into the pericapsular space, we reach the terminal articular branches of these nerves, which are indistinctly from their origin. Furthermore, through the wheat birch foramen and natural capsular foramen, which is between the upper and the middle glenohumeral ligaments, we also can reach potentially the intraarticular space, that is the true glenohumeral joint. This foramen of wheat birch is a small opening between the two ligaments in the glenohumeral joint capsule, that is between the superior and middle glenohumeral ligaments, and is seen communicating between the subtendinous bursa of the subscapularis muscle and into the subcoracoid bursa as well. There is always something very inconsistent between the middle and the inferior glenohumeral ligament, that is the foramen of Rouvier, which is also a potential communication between the space which we are actually injecting beneath the subscapularis and into the true glenohumeral joint. Possibly, this is the reason why we are able to inject into the glenohumeral joint through this SHAC axis. This is an important image which needs to be discussed prior to this intervention. This is a sagittal drawing and corresponding MDCT orthographic image of the normal glenohumeral anatomy. Here we have these three arrows. The black arrow which indicates the superior glenohumeral ligament, the middle glenohumeral ligament, and this is the inferior glenohumeral ligament. That's the anterior band of the inferior glenohumeral ligament. And these communications which we can see here, actually there are communications here actually. That is the top one, which is the uh, foramen of Wheatberg, which is actually communicating between the superior and the middle glenohumeral ligament. And there is one which is there actually between the middle and inferior glenohumeral ligaments, that is marked by the asterisk, which is the foramen of Rouvier. So this is very, very important to know prior to actually performing this intervention. Let us see a couple of uh, arthroscopic images before we actually perform these interventions. The superior, middle, and the inferior glenohumeral ligaments. That's a glenoid, that's a bony glenoid, which is marked as G here. That's a humeral head. And you could see a couple of foramens here. This is the foramen of Wiedberg, and this is the foramen of Rouvier, which are potential spaces through which actually we are able to access the glenohumeral joint. This is another interesting image where you could see the subscapularis tendon and you could see the middle glenohumeral ligament. And we are actually getting into this space when we actually do a SHAC approach for the glenohumeral joint injection. When your needle tip is here, it is bound to get into the glenohumeral joint through this foramen of Wiedberg's. Now, it is time to demonstrate this procedure. The patient is in supine position with a slightly externally rotated shoulder. I'm using a sterile prepared probe and the field. After local anesthetic infiltration, I'm just giving 10 ml of 1% lignocaine prior to injection of around 40 ml of sterile normal saline. So there is a free flow of the normal saline. You could see there is a regurgitant fluid. That regurgitant fluid means that it is confirmatory, it is very much within the joint. Sometimes you may not be able to see the needle tip properly. That is why this particular step is very important. And also try to see the subscapularis myotendinous junction below which I have the needle tip. I'm injecting saline into it. I could see real time it is spreading into the joint space. This is the coracoid for you without any coracobrachialis and the short head of the biceps being seen. Since we have a significant amount of capsulitis, we always need to inject around 20 to 40 milligrams of triamcinolone into the joint space for better pain relief and mobilization after the procedure. Now, trying to explain what exactly has happened. This is the coracoid process. Generally, there is always some small little muscle which is seen above the coracoid process. You could see the coracobrachialis and the short head of the biceps. When I put the shoulder into slight external rotation, you could see the myotendinous junction, which is actually coming out. This is part of the tendon. So generally, if you do it in a slightly medially rotated shoulder, you could end up, your needle could end up into the substance of the tendon, which probably will not allow you to inject. So always try to do this slight external rotation maneuver. Try to get this myotendinous junction in view. Get your needle through the muscle and go under the subscapularis muscle so that you get underneath this space, which is exactly your space where you want to inject. That is the anterior capsular area. And there you would try to inject local anesthetic with steroid with saline, and see, you could see the spread, nice spread here. Actually, sometimes you will not be able to see the needle tip, so that is always like, it's always good to actually not advance beyond this, so that you will lose visualization of the needle if you actually advance beyond this. Thank you so much for your patient listening.